Hi, my name is David Sturt. I'm one of the registrars and anaesthesia at Chest for the moment, and I'm going to talk through the adductor compartment block that we are introducing at Chest at the moment as a form of rescue analgesia for patients in pain after a total knee replacement. It can be used in other scenarios as well, but that's what we're going to focus on today. So I thought I would talk about why we're thinking of introducing this block. So what we've done is all the data collected on total knee replacements over a period of time. We've done 2 audits, and it's been fairly consistent that we've demonstrated that patients who have a lot of pain on the first post-operative day struggle to mobilise and have a longer overall length of stay. It just seems to be the pain on day 1 post-op seems to influence the overall length of stay. So that led us to thinking, how can we deal with pain on that first post-operative day and make it, in those that have severe pain, now the physios usually score the pain 0 to 3, and we're talking about patients who score their pain as 3, who struggle to get up and about and have a longer duration of stay in hospital. So we're looking to address that group of patients. And the idea then is that if we can control their pain better, then they will engage far better with the physiotherapists on that first operative and post-operative day and the second post-operative day, etc., and get out of hospital sooner as a result of that. So how are we planning to improve the pain? So there are a few things we've been introducing, and we've put that together to form a protocol which we've got on the internet now. Now, one of the strategies that we've come up with, particularly to address day 1 post-operative pain, is, as I've mentioned, a form of rescue nerve block. And this is the adductor compartment block. So the idea would be for the nursing staff on the ward, usually on ward 41, to identify patients scoring at 3 on a 0 to 3 pain score. It might be the nurse staff or the physiotherapists, in fact. They would then potentially contact the night senior house officer on call for anaesthesia, who would then either do the adductor compartment block or arrange for the team in the day to have the block done, ideally very early on in the morning, so before 8:30 if possible. The idea of that being that then the patient would be able to fully engage with the physiotherapists. So I'll just talk a little bit about what the adductor compartment is. So the principle that we're using is that the nerves generally follow the path the blood vessels follow. So up the top of the thigh, as you're probably aware, the femoral nerve lies directly next to the femoral vessels, and that configuration sits within the femoral triangle at the top of the thigh, just beneath the inguinal ligament. Now, as the vessels move down the thigh, they sort of move slowly, more medially, and around the junction between the proximal third and distal 2/3, or even the mid-thigh, the vessels slip underneath the sartorius muscle, which is a long muscle which runs all the way down the front of the thigh from the lateral to medial direction, sort of oblique. Now, as the vessels slip underneath the sartorius muscle, they enter what's called the adductor compartment, which is a sort of triangular-shaped fascial compartment. The roof of that compartment is the sartorius muscle, and then the other 2 sides of that triangle, more medial, is adductor longus muscle, and more laterally is the vastus medialis. And it's into that fascial plane and potential space that we're aiming to introduce a needle and inject local anaesthetic. Now, this picture here, we've stripped away the sartorius muscle so you can see what underlies it, so within the adductor canal. As I said, the femoral vessels lie there, and adjacent to that, some branches of the femoral nerve which supply the knee joint, and that's what we're aiming to block to provide analgesia for these patients. Now, as you move down the thigh and into this compartment, the branches of the femoral nerve become more and more predominantly sensory. So the idea behind this is that blocking the branches of the femoral nerve which supply the knee at this level will predominantly block sensory nerves as opposed to motor nerves. Now obviously you want to preserve the strength of the muscles of the thigh to allow the patient to mobilise the next day. And that was a drawback of we primarily used to do femoral nerve blocks and sciatic blocks in combination or each on their own. Often patients would have a degree of muscular weakness the next day which might impede their mobility. So the idea behind this block is that it does provide analgesia but avoids the muscular weakness that you get with other more proximal blocks. So this is cross-section here, just to help you visualise where the adductor canal is in relation to the other muscle groups and the bones and overall the anatomy within the thigh. Within the canal, as I mentioned, the distal branches, sensory branches of the femoral nerve. So this includes, you might be familiar with, the saphenous nerve, and also potentially contains nerve to vastus medialis, which does have some branches to the knee, sensory branches. And in some patients, there is a branch of the obturator nerve which supplies the knee joint as well, which we're able to block within the canal too. So we'll talk through a little bit what's involved with the block. It's pretty easy to do. We can do it on the ward. All you need is an ultrasound probe and a 100mm block needle. You don't need a nerve stimulator with that needle. You need a set of syringes, a 5, 10 and 20mm syringe. You need some lidocaine and an orange needle. The lidocaine and orange needle is just to infiltrate the skin, so you anesthetize the skin so you can actually introduce the block needle because the patient will be awake when you're doing it. So you also need a dressing pack, some chlorhexidine to prepare the skin before, and you'll need some levobupivacaine. You need to dilute that down, and the dilution we've suggested in the protocol is 0.125% levobupivacaine. So you may need to take some 0.5 or 0.25% levobupivacaine and then some saline or water rejection and dilute it down into 30 ml total volume. And this volume should hopefully spread up and down the adductor canal and anaesthetize the nerves within the adductor canal as I've mentioned. So this picture just demonstrates the sort of approach. Now this is the patient's right leg. It will depend whether you're left-handed or right-handed with your needling technique, which direction you're facing down towards the patient's caudal end or facing more towards cranial end of the patient. These are the sort of images that you will pick up. Now, if you're a right-handed person and you're sitting and you're doing a block on the right patient's right leg and you're looking down towards the caudal end of the patient, this is the sort of view you'll see. So on the medial side of the compartment, or medial side of the adductor canal, you'll see the adductor longus muscle. You'll see above the canal the sartorius muscle, and on the lateral side of the canal you'll see the vastus medialis muscle, and within the canal you'll see the pulsation of the femoral artery. And usually with a bit of compression you may not see the femoral vein. Then within this picture, above the sartorius muscle you can see subcutaneous tissue, which depending on the patient's habitus, the size of which or depth of which will vary. Now this picture here just demonstrates the orientation of the needle as it's advanced down towards the adductor canal. You may well feel a pop as it enters Now you're aiming to inject the local anaesthetic toward the medial, towards the lateral side of the artery. Underneath the sartorius muscle and around vastus medialis. And this is usually where most of the nerves lie. So you're aiming to inject lateral to the femoral artery within this adductor compartment. And you need to hopefully place your needle appropriately and obviously aspirate to make sure you're not in the vessel once you feel your tip is within the adductor compartment. And obviously every 5 mils or so, advise aspirating again and repeatedly so that you confirm that your needle hasn't migrated within the femoral artery. And hopefully you'll see the potential space open up as you inject these 30 mils of 0.125 bupivacaine into the canal. And then you're done. So there's a little video here that's been produced by some other doctors over in America. So they'll talk through again exactly what's involved in the blocks step by step.
Go ahead and start by prepping the thigh here. And we're going to be going, as we talked about in the intro there, a little bit higher in the thigh since we're doing this adductor canal catheter preoperatively. And we'll be taking an oblique angle of the needle from proximal to distal in order to insert more proximally as well as thread the catheter down the canal from cranial to caudal, proximal to distal. And remember, the key is for that lower margin of our dressing to be 3 4-finger hand breadths above that cranial border of the patella. So right about here is the lower margin of where we want our dressing to be. So we'll start a little bit higher than that. Our initial bolus is going to be with 10 cc's of 0.5% bupivacaine. Another common misconception with adductor canal blocks for knee surgery is that you need to use 20 or 30 cc's of local anesthetic. In most cases, we're able to get great analgesia with just 10 cc's. And it's like popliteal blocks where the local anesthesia really does spread up and down that canal quite a bit, and around for that matter. Okay, so we've found our position with a short axis view. And I'll point out a couple of anatomy structures there. This is the femoral artery, about a little bit more proximal than the mid-thigh. This is the sartorius muscle just above the artery. Just anterior, lateral, just anterior to that artery to the left, at about the 9 o'clock position is the saphenous nerve. The vastus medialis muscle is this muscle just deep to sartorius. And we're going to look to thread our catheter in that adductor canal, which is just lateral to the artery, anterior to the artery, just deep to sartorius, and just superficial to that vastus medialis where the saphenous nerve lies. Okay, so that's a cross-sectional short-axis view. And notice if I slightly rotate my probe, it'll allow me to insert more cranial in plane, and also the needle angle will be slightly oblique down the adductor canal, which will allow the catheter to thread more easily. Notice, though, that the view on the ultrasound screen doesn't change much. You can still see a pretty clear hyperechoic area where that saphenous nerve lies. And it still looks very similar. So go ahead and infiltrate. You can feel a big bee sting, about 4 or 5 centimeters from the probe. We'll insert our non-stimulating 18-gauge TUI from anterior to posterior in the slightly oblique direction, proximal distal or cranial caudal. You can see the needle approaching from left to right on the screen. It'll be a transsartorial technique, meaning we'll go through the sartorius to get to the adductor canal. If I relax the pressure, you can see just deep to the saphenous nerve, the femoral vein, which you have to be cautious about not entering. So I'll feel a little bit of a pop as I get through the sartorius muscle. Okay. I'll go ahead and give 5 cc slowly there and look for that space to open up. Advancing my needle slightly. You can see now the saphenous nerve is sort of bouncing superficially and away from the injection. Okay, that's half of our injection. We'll give the last half to open up the space a little bit, 5 more cc's. That's written inject. Okay. Now we've created some space in that adductor canal. We'll be able to thread the catheter.